if you miss anything, we can always go back and see the webinars. So there'll be a lot of information presented today. So a good way to do that is to go to youtube.com. You can search for Myeloma Canada. You can subscribe. If you click on the little bell, you'll get a notification every time we put up a new webinar. Now, you can also access them from the resources section. We go to resources, educational videos, and then that'll bring you to the YouTube channel. To ask questions, you'll notice on your GoToWebinar panel, you'll have a little tab that says questions. Type in your questions, send them to me. At the end of the webinar, we'll go through all the questions, and and our presenter will answer them for us. So without further ado, I'd like to introduce you all to our presenter today, Dr. Evangelos Terpos, who is Professor of Hematology and Director of the Stem Cell Transplant Unit of the Plasma Cell Dyscrasias Unit at the Department of Clinical Therapeutics at the School of Medicine at the University of Athens in Athens, Greece, obviously. Dr. Terpos, thank you so much for making the time for us. I know that the clinic has been very busy these days, and so we really appreciate you coming and teaching us a little bit more about COVID-19 vaccination and myeloma.
Thank you, Gabriel, for the very nice introduction in Myeloma Canada, for the invitation. If you allow me to share the screen in order to show the slides. Can you hear the slide? Can you see the slides?
Yes. We just don't see you for some reason.
Okay, I'm going to put it
no, I see you.
In a full screen. Okay. All right. So I think that it is extremely important for both the patients and the caregivers to know exactly what to do with the COVID-19 vaccinations, because many times the patients ask me why we do not respond to the vaccine, why, although we had the vaccine, we have also COVID-19 infection, so what's happening, and all these things. So it is important to know I don't know if you continue to see my screen. Okay. It is important to know what to do with the patients who do not respond, or why, even though we have responded to treatment or to a vaccine, we may have COVID-19. So first of all, this is my disclosure that AstraZeneca is only relevant to this presentation. And we know from many years now, during the last 2 years, that COVID-19 unfortunately is responsible for more than 600 million confirmed cases now, and only in Europe, as of June 1st this year, more than 220 million cases happened. So it is a real pandemic, and you can see how the different waves of the disease came. And we have to say that hematologic malignant patients have poor outcomes if they are infected by COVID-19. Although these data come from the Wuhan virus, so the first virus, and alpha and beta mutants, we do know that a meta-analysis involving 3,000 and more patients from that period of time, almost 34% of adult patients with hematological cancer died due to infection if they were infected. Patients who were more than 60 years of age had a mortality rate of around 50% at that time, and those who received therapy and they were non-white had a higher mortality rate. If we go to myeloma, there is only one study conducted by the International Myeloma Society in the first period of the pandemic, and this is extremely important because at that time we had high mortality rate, which was up to 40 to 50% in some cases, as in patients above the age of 70, but you can see that the mortality rate was 40%. And of course, this mortality increased with age. Factors that correlated with higher risk of death in myeloma included the stage of the disease. So if someone had stage 3 compared to stage 1, those who had high risk myeloma compared to the others, those who had renal insufficiency had almost 2 times more probability of death if they were infected, if the patients had active or progressive disease compared to those who were in complete response, had 2.1-fold higher probability of mortality, and those who had more than one comorbidity had more than 1.5 times higher probability of death. So you see that during the first wave of the pandemic, we had very high mortality in COVID-19 patients with multiple myeloma. Compared to healthy individuals, those who are immunocompromised fail to respond in 3 key ways to the vaccines. First of all, the quantity of the vaccine is 1.3 to 23 times lower compared to the healthy individual. So first of all, we have lower quantity of the antibody levels after 2 vaccine doses. Second, and more importantly, is that these lower antibody levels are having lower functionality. So they have 32 to 64 lower neutralizing activity by these antibodies. What neutralization means? It means that this antibody can make the virus not to go into the human cells. And the third important part is that this antibody decline over time, and this reduction from month 1 to month 6 is 64% compared to that of a healthy individual. So we have 3 key elements that the myeloma patients cannot respond to the vaccine. Even after booster doses, up to 45% of immunocompromised patients remain unprotected, and we are going to see exactly what's happening in multiple myeloma. But it's extremely important for you to understand the difference between the binding antibodies and the neutralizing antibodies. So the body, for example, can produce antibodies that can bind to the virus, but unfortunately, this antibody does not mean that the virus cannot go into the human cell. In order these antibodies to make the virus not to go into the human cell, have to have neutralizing activity, meaning to make the virus inactive. So the binding antibodies are important only if they are able to neutralize the virus. In order to give you an example to that, the HIV is a virus that our body produces a lot of binding antibodies. That's why this is the first test that we are doing against HIV. And if we have binding antibodies, this is considered positive. But the patient has the disease because these antibodies cannot neutralize the virus, although they bind to it. The second is that although we have a lot of FDA-approved tests for binding antibodies, we have only 2 tests approved for neutralizing antibodies. And also, when we say antibodies, we talk for a specific area of the virus, in this specific area that the virus binds to the ACE receptor in order to go into the cell, and this is called RBD, which is the receptor binding domain of the spike protein of the virus. The problem is that all these tests, both the ELISA or the binding antibodies test and also the neutralizing test that are commercially available, are targeting the RBD part, the receptor binding domain of the spike protein of the Wuhan virus. So they cannot detect antibodies against specific mutants. I talk always for the commercially available kits. This is what's happening regarding neutralizing antibody in patients with multiple myeloma. Although these curves may be a little bit complicated, I will try to make it easy for you to understand. First of all, with the red bullets, we have patients with multiple myeloma, and with the blue bullets, healthy individuals of similar age and gender. You can see what's happening before the first vaccine dose. This is day 1. Day 22 is the day before the second dose, and day 50 is 1 month after the second dose. And the same results for the healthy individual. So the neutralizing, these are the titles of neutralizing antibodies, and are expressed are percentage of inhibition of the virus. So everything which is above 30% is considered positive. And in order to say that this is a clinically relevant inhibition, meaning that if the patient or the person has this title, is protected by a viral infection, has to be more than 50%, suggesting that the antibodies of his or her body can neutralize the virus at least of 50% or more. Of course, as we go up to 100%, this is the absolute protection. So you can see that after the 2 doses of the vaccine, if we see the blue color, healthy individuals of similar age and gender with myeloma have a median neutralizing activity of 90.6%, suggesting that their bodies have antibodies that can neutralize the virus at the level of 90.6%. And we talk always about healthy individuals that neutralize the Wuhan strain of the virus, the first one in December 2020, not the new ones. This is extremely important in order to understand the differences that we have now. But even against that Wuhan virus, patients with multiple myeloma, after 2 doses of the vaccine, the full vaccination, can have a neutralizing activity in their bodies of around 60%. So this means that almost 50% of the patients have non-clinically relevant inhibition of the virus. If we see if there are differences between patients with active myeloma versus patients with monoclonal gammopathy of undetermined significance or patients with asymptomatic myeloma, you can easily check that patients with MGAS are behaving like the healthy individuals, while patients with multiple myeloma, as you can see here, have a 22% lower neutralizing activity compared to MGAS patients. Why we have a lot of patients who respond to vaccine, even against the Wuhan strain, and a lot of patients who do not respond to vaccine? They are almost 50-50, with a 30% of having very good responses and a 40% of having very poor responses. We checked what are the most important factors for not achieving good neutralizing responses to the vaccine, and we have seen that these factors include the low levels of lymph cells in the blood, below 1,000 cells every square centimeter of the blood, the presence of therapy with anti-CD38 based antibodies or anti-BCMA based regimen. So you can see here that those patients who receive anti-CD38 like daratumumab or anti-BCMA based regimens like belantamab mafodotin have a very low neutralizing response after the 2 vaccine dose of 32% versus 64% of all the other patients. And the Mount Sinai group showed very nicely, not using a neutralizing assay, but an assay that measures binding antibodies against the spike protein of the Wuhan virus. Again, I always say against the Wuhan because this is extremely important. And you can see that those patients who receive daratumumab, for example, or belantamab mafodotin or CAR T cells, 20.5% and 42% cannot have a good response to the vaccine. Other factors, except of these two therapies that are extremely important for developing antibodies, is the response status, if the patient achieve a complete response or not, and again, the grade of lymphopenia in the blood. Another important issue is the patient who is vaccinated versus the patient who has already had a COVID-19 infection. The myeloma patients after a COVID-19 infection have higher neutralizing antibody activity compared to that activity that is achieved by a vaccine. And this tested 4 weeks after either diagnosis of COVID-19 or after the full vaccination. However, this is only the one part of our immune system against the virus. So we have the so-called humoral response, meaning the antibody responses, but also we have the cellular response, the T cells that can attack to the virus and kill it. Unfortunately, with the red color here, we have patients who do not respond to the vaccine according to antibodies. And with the other colors, we have patients who respond to the vaccine and they produce antibodies. Unfortunately, those patients who do not respond to the vaccine in producing antibodies, they have very low cellular immunity, meaning that these patients are almost unprotected against the virus. This is why the 2 vaccine dose cannot protect our myeloma patients. And in these patients, out of 7,000 breakthrough cases, patients with multiple myeloma were at the higher risk of breakthrough infections compared to non-cancer patients or patients with solid tumors, because you can see here treatments that are given to myeloma patients like proteasome inhibitors, like Velcade, immunomodulatory drugs like lenalidomide, CAR T cell therapies, or monoclonal antibodies like daratumumab. All these therapies are associated with higher risk of breakthrough infections. Why? One reason is because the humoral response, the antibody response to the vaccine, is low to these patients. So, what's happening with the booster dose? Can a booster dose increases the neutralizing antibody against the virus? And indeed, the median antibody titer against the virus before the 3rd dose increased from 27%, so the majority of the patients have non-detectable neutralizing antibodies, to 96.7% 1 month after the 3rd dose. So see what happened here. Here is the day 50 of these 167 myeloma patients. So 1 month after the 2nd dose, you see that the median is around 60% here, and approximately 4 months after, you have a dramatic reduction of the antibodies from 60% to less than 30%. I remind you that 30% is the level of positivity and above 50% is the level of protection. So you can see that in this level, we had less than 1/3 of the patient. So after dose 3, of almost 70% of patients who had NAb titer below 50%, this is the 70%, almost 65% of those managed to increase the neutralizing antibody titer to more than 50%. And of this 1/3 of patients who had a neutralizing antibody titer below 30%, more than 50% of those achieved a titer of more than 30%, and another 45% of them achieved a protective titer. But always we talk about antibodies against the Wuhan strain. I always mention that, but because this is extremely important in order also to understand the second important reason that we may have breakthrough infection, even in these patients. The boosted dose produce high antibody levels, especially in those who had the previous infection, but even in those who had not COVID infection, and those who receive anti-CD38 or anti-BCMA targeted therapy, again, they have a higher antibody responses after the third dose. However, as you can see here, the anti-BCMA targeted therapy have lower increase compared to all the other groups. But these are antibodies against the Wuhan virus. How about the Delta and especially the Omicron variants that are now in the community? Unfortunately, we don't have commercially available tests, but also our research lab can do this measurement. And this comes from the Mount Sinai group, who showed very nicely that these are the results of multiple myeloma patients for the Omicron after the booster dose. And these are the antibodies, the median, if you want to check according to Omicron variant, suggesting that although the neutralizing activity is more than 40% for the majority of the myeloma patients are able to neutralize the Wuhan virus, if we go to Omicron, the vast majority of the patients have no protection against the Omicron. And I think that this is extremely important. Even the healthy control have much lower protection against Omicron if they are fully vaccinated compared to the Wuhan. And this is normal because we are vaccinated against the Wuhan strain, not against the Omicron. Now, of course, the new vaccine includes the RBD of the Omicron 4 and 5, but these are available since August. So, for example, to give you my personal experience, I had been vaccinated with a booster dose in November. In June, my neutralizing antibodies against the Wuhan virus was more than 97%, so I had full protection, but against Omicron 4 and 5, I had only 13% of protection, suggesting that I had no protection against Omicron, even if I was fully vaccinated, and that's why I had COVID in June. The cellular immunity, I don't want to go into details in this complicated slide, but also suggest that the cellular immunity against Omicron is much lower compared to the Wuhan or the Delta variant. And this is our data for that, for myeloma patients off therapy, myeloma patients on therapy with daratumumab or belantamab mafodotin, and on therapy with proteasome inhibitors and thymine. So you can see here in 17, 12, and 17 patients what happened against the Wuhan variant, the Delta variant, the BA1, this is Omicron 1, Omicron 2, and Omicron 4-5 that are now in the community. What you can see is that after the booster dose, all myeloma patients have had protection against the Wuhan, 17 out of 17, but half of them off therapy had protection, 47% of them, against the Omicron 4 and 5. How about patients who are receiving daratumumab or belantamab mafodotin? Although almost all of them had protection against the Wuhan variant, which is the variant against to whom we are vaccinated because we are receiving the vaccine against the Wuhan variant, only 25% had protection against the Omicron 4 and 5. Similar results with those who receive the ICE and DINES, only 30% have protection against the Omicron 4 and 5. And that's why, although the myeloma patients, like the healthy individuals who are fully vaccinated, are infected by COVID-19. Do myeloma patients protected from a second boosted dose? If it is the same dose against the Wuhan, you can see what's happening after the 2 doses. You can see the reduction in the antibody titers. If here you receive a 3rd dose, you can see again the strong elevation, but we see a slighter reduction after the 3rd dose, and with the 4th dose, we go back to what we had after the 3rd. But again, these are data against the Wuhan variant. However, patients who receive BCMA-targeted therapy, even with the 4th dose, after 1 month, they have very low response to therapy, while patients on daratumumab and other therapies with the 4th dose are responding very well. But you understand that this response against the Wuhan virus means that you have protection against the Omicron around 25 to 30%. So in conclusion, in order to have some time for questions, we can say that patients with multiple myeloma, and the same is for those with Waldenstrom macroglobulinemia, have lower antibody responses against primary vaccination, especially those under immunotherapy or targeted therapies, especially those who receive anti-CD38 or anti-BCMA-based therapy with daratumumab, isatuximab, or belantamab mafodotin. The booster vaccine dose increased the neutralizing antibody titers against all SARS-CoV-2 variants, but at low levels against the Omicron, and especially Omicron 4 and 5, compared to normal control. The booster dose produces neutralizing antibody titers against Omicron 4 and 5 in 50% of myeloma patients off therapy, but only in 1 out of 4 of those under daratumumab or belantamab mafodotin-based treatment, and in 1/3 of patients under proteasome inhibitor and IMiD-based therapy. The second booster dose enhances the neutralizing antibody production, which is reduced by time after the first booster dose, but having into consideration what the numbers are for Omicron 4 and 5. So, as we are having now a new vaccine against 4 and 5, it is the best to have this vaccine. And we don't know how protected we are. We are doing the test now, but I believe that like the Wuhan virus, the majority of the patient would respond and produce good neutralization against Omicron 4 and 5. Would it be enough for the new variant, the BQ121, that is now the dominant mutant in the New York State, for example, which is near Canada, and possibly it's going to be the mutant that will conquer in Canada till the end of the year or the winter 2023? We don't know, but definitely it's going to give some protection because the BQ1 is coming from the Omicron 5. So it's a mutant that has derived from the Omicron 5. So I assume, although I do not have the full data, that this can give some protection. Another important issue is the prophylactic monoclonal antibodies against the SARS-CoV-2. In many centers in the United States, those patients who receive daratumumab or other anti-CD38 therapies, belantamab mafodotin or other anti-BCMA-based therapies, receive Evusheld. What is Evusheld? Evusheld is a double monoclonal antibody. We call it Tixasilga for because it's a difficult name to produce all of it. And it is monoclonal antibodies. I mean antibodies that are given to the patient, like the IV immunoglobulin. So they are prepared antibodies against the virus that are given to the patient to protect them. And what we've seen from that is that in the era of Omicron variant, when the Omicron variant was the dominant, or like our era now, because Omicron 4 and 5 is dominant, out of this big number of patients who are more than 670 patients who are given the monoclonal antibody, you can see that during the next 2 months, only 1.2% of them were positive for the virus. And of those patients, if you can see, only 7 were vaccinated and 1 non-vaccinated. And regarding hematologic malignancy or autologous transplant patients, only 3 patients with hematologic malignancies and 1 who had received an autologous transplant were infected. What we are doing in Greece is that in all patients who are receiving with multiple myeloma, daratumumab or belantamab mafodotin, because these are the 2 only therapies that have been licensed as anti-CD38 and anti-BCMA in Greece, along with esatuximab. All these patients are receiving Evusheld. They received the dose in August when the Evusheld was available for the patient. It lasts for 6 months. It is extremely efficacious for Omicron 4 and 5, but unfortunately, it cannot neutralize the new variant, the BQ1 and the BQ1.1, the variants that I mentioned to you that are now dominant in the New York, and possibly by winter 2023, they will be the dominant in the whole US country. So, having all this, I would like to thank you for your attention. I hope that I try to make it as simple as possible for you. I would like to thank all my colleagues that we work together in the Department of Clinical Therapeutics, in the Department of Biochemistry and Biology of our university, and especially of 2 special professors in the NCI, the National Cancer Institute, George Pavlakis, who is a Greek of Greek origin, and Barbara Felber, because they gave us the opportunity to have the strains, the new variants, and present you the data for Delta and Omicron that I show you. They gave us the opportunity and the technology that we wanted that we needed in order to make the measurements of the antibody against the mutants. What we are doing now is that in those patients who are receiving the vaccine against the 4 and 5 Omicron, the new one, and in those patients who were infected by the Omicron 4 and 5 during summer, we are measuring their antibodies, the neutralizing antibodies, against the BQ1 and Q1.1, the new 2 mutants that are going to be the dominant during winter, in order to know if the patients were vaccinated with the new vaccine that targets Omicron 4 and 5, or those who were infected by the Omicron 4 and 5 are able to neutralize the new mutant in order to be a little bit safer for the Christmas vacations. And with that, I would like to thank you for your attention, and I'm happy to have questions.
Thank you, Dr. Terpos, for that great sharing all that data. I know that a lot of it is in press, and so we really appreciate it that you shared it with us. I don't know if everybody on the line knows how fortunate we are to have Dr. Terpos here today, because there's not a lot of people in myeloma who are doing research with the vaccines, and so Dr. Terpos is probably the only one, or one of the only ones, and so thanks again. So we got quite a few questions here.
Okay. In summarizing, I want to make 2 important things for the audience. First is that if you are vaccinated against the Wuhan virus, this does not mean that you are protected against the Omicron. It is totally the opposite. As you have seen, it is probable that you are not protected, so get the vaccine against the Omicron 4 and 5. And the second is that this is extremely important also for the other members of the family that they live with you. So it is important for them also to have the vaccine, not only to protect themselves, because if they are healthy, the Omicron 4 and 5 seems to be rather mild or moderate for the healthy, but definitely not to protect you from the from the infection. Just to let you know that although I work in a hospital and I see COVID patients also with hematologic malignancies, and in my transplant unit, I was infected only when my daughter was infected and came at home. So I was not infected by the hospital, not by the COVID patients there, but my daughter when she was infected by COVID in summer.
Thank you. So that, I mean, that's definitely an amazing recap and great take-home point. You spoke about the prophylaxis with Evusheld, that product there with monoclonal antibodies. What about the other product, the oral pill Paxlovid? Is there a role in myeloma treatment for that?
No, there is a big role in the treatment of COVID-19, but not of prophylaxis. So prophylaxis means that you are not infected by the virus and you are receiving antibodies that have been produced against the virus. They are, let's say, ready-to-use antibodies. They are given intravenously with one infusion, and then you are protected for the next 6 months in a very high level. I mean, we've seen what it happened in our almost 100 patients that have been given the Evusheld in August. None of them has been infected, although because of having this infusion, they were a little bit more free. They have no masks when they went to restaurants and all these things. So we had no infection by the Omicron 4 and 5 in these patients, and that's why I recommend it, especially if you know that in your community Omicron and Omicron 4 and 5 are dominant. Of course, as I told you previously, the Evusheld is not active against the new virus, the BQ1 and BQ1.1 that are now dominant in the US.
Thank you. So for that
Paxlovid, because you asked about Paxlovid, is an antiviral drug that is important to be taken when you are infected. So when you have some symptoms of sore throat, of fever, of cough, and you are doing the test and you are positive for COVID-19, then you have to take immediately the Paxlovid. What we have seen with Paxlovid, Paxlovid has one thing that we are now, let's say, learning in the scientific community. There is a rather good number of patients, around 20% with myeloma. This is what I've seen in my practice, that they are receiving Paxlovid and they are going extremely well. So after 2 days, there is no fever, no cough, whatever. They are doing the test again after 5-6 days, they are negative. And then 10 days after, they have become positive again. This is considered as a rebound phenomenon with Paxlovid. And what we are doing now in Greece is we are conducting a trial with the second 5 days Paxlovid administration, and we have in these patients with the rebound phenomenon, we have seen that they are doing extremely well, and with this second dose of Paxlovid, they managed to become negative with no symptoms of the virus. So keep in mind that myeloma patients may have this rebound phenomenon, and they may have to be retreated with Paxlovid 10 days after their initial dose if they become positive again.
Good, thank you. Going back to the Evusheld, someone's asking about side effects. Have you observed any specific side effects in terms of that?
Outside of allergic reaction, which is something common in intravenous immunoglobulins, there were no other things. We had 1 or 2 only patients who received Evusheld because we given that in our center who had an allergy to that.
Okay, cool, thank you. So a lot of the questions we're getting have to do with transplant, and so a lot of the questions are, should we be vaccinated before the transplant? What time point should we be vaccinated after the transplant? So can you maybe just take us through maybe your mind? You have a newly diagnosed patient in front of you who probably either has no COVID vaccination or maybe has 2 doses. What would be the recommended dosing schedule in terms of
recommendation? First of all, you know that the patients have to receive 4 to 6 cycles of induction therapy. In Greece, we are using daratumumab in the induction. I don't know if this is the standard therapy for Canada. Probably not. I know that VRD is more or less used in Canada. So if you don't use daratumumab, this is much better for the vaccine, of course, because the probability of response is very high. So if someone has received 2 doses before the induction therapy and now is on induction, then before transplant, I would give, when the patient has responded to therapy, the new vaccine against Omicron 4 and 5. If the patient, let's say, has received the 2 doses during the induction phase, because this was the case at that time, then I would strongly recommend during the month, because between the last treatment and the transplant, there is 1 till 3 months, the majority of the case, so you don't go directly to the transplant. And as the patient is in remission, I would recommend to have the new vaccine. So as a 3rd, 4th, 5th dose, I don't know how many someone has done in Canada, but if he has not done the Omicron 4/5, I would strongly recommend the Omicron 4/5 vaccine before transplant.
And then after the transplant, though 3 to 6 months after, is that the recommendation? Do you have to redo them, or do you get 2 doses? What's the recommendation?
This is a big issue because we don't know how it goes. I mean, you have given, it's not only the transplant question, it's also a question even for the other patients that are receiving therapy. They are in maintenance therapies with lenalidomide, or they are receiving continuous treatment. So what we are going to do for these patients? Do we need to re-vaccinate them after 6 months? It depends. From what, you can tell me? From the research that we are doing against the new mutants. This is a whole marathon that we are running behind the virus. So in the majority of the cases, we have a new vaccine that targets Omicron 4/5. And this goes very well. The problem is, can this protect us against the new mutants, the BQ1, the XB1 that also may come? I don't believe that this is going to be a dominant mutant. The BQ1 probably is going to be a mutant who is going to dominate. But this mutant comes from the Omicron 5. So possibly being vaccinated against the Omicron 4/5 gives you some protection. How much? We don't know. How long it's going to be in your body? We don't know. Is it going to be reduced like the previous neutralizing antibodies, like the Wuhan virus? Possibly yes. So in that case, you have to repeat it after 6 months if you are on treatment. But also we need to check that. The problem is, as we are producing data, and you see now the data for Omicron 4/5, and we are extremely fast on that, because we need also to have the whole virus to isolate the specific protein to produce the antibodies that we are going to measure and do the measurement. You understand that we have a new mutant, and till having the publication that now is going to come, I mean, the new mutant is going to conquer in the area. And we don't know how relevant our data will be for this mutant. But for myeloma patients, I would recommend, even if they have the Omicron 4 and 5 vaccine, if the BQ1 comes to the area, not to say that, okay, I have taken Evusheld, I have done the vaccine, I'm not going to wear any masks when I am in close indoors, or when I'm indoors and with a lot of people, because this may create problems. And sometimes in immunocompromised patient, the COVID-19 is not so mild like in the healthy individuals. And also we have the long COVID, don't forget that. We have a lot of data now, and we have a long COVID clinic in our institute, that we have patients who have been infected 3 times from COVID. I mean, in the initial Wuhan virus, bad one, the Delta, and then the Omicron, although they were fully vaccinated. And because of that, the long COVID symptoms that they have make their everyday life very difficult. So it's good not to be infected, if possible.
Mhm. So even though we don't have the data, after the transplant, if you do, you get one booster of the bivalent vaccine. It's expected that after, let's say, 6 months, just like the wild type, the response will go down, and then another booster would be recommended at that point.
Yeah, but with the same vaccine. This would be the question. It's like the Wuhan. I mean, with the booster vaccine of the Wuhan, I said many times that yes, you have to do the booster. For me, for example, the booster was in November 2021, but at that time, that booster protected against the Delta. So, I mean, even in the hospital, no staff, I mean, nursing staff or doctors were infected by COVID-19 in the Delta. But then when Omicron came, one by one started to be infected because the vaccine had no protection against Omicron. So the question is how much we are protected if we are having the Omicron 4 and 5 against the Omicron BQ1, for example. We don't know that. So when we have the data, we will feel more relaxed. But till having the data, it's better at least to be protected. Yes, having a Vucelt, having the Omicron 4-5, but also we have to be protected. And if we know that someone has infection symptoms like sore throat or fever, it's better not to go close to him without a mask.
Okay, thank you. So we saw that you had lower response with people who are on BCMA therapies or anti-CD38, was a bit better than BCMA now. In terms of timing, like should the vaccine be timed, a few weeks before the treatment, a few weeks after the treatment? Does it make a difference?
All the data that you have seen are for patients who were on treatment at the time of vaccination. We have seen that there is no, even if you stop, for example, for 1 month, the daratumumab for those patients who receive monthly doses of daratumumab, if you skip one dose in order to see what's going to happen, this does not mean that you will respond to treatment. The same with anti-BCMA, because all these drugs, let's say, kill your normal B cells at a very high level, because both BCMA, especially BCMA, and at a lesser extent CD38, are found in our normal plasma cells that are producing the normal antibodies, but also in the normal B cells, so the B lymphocytes. So if you have received the drug, they kill almost everything. It's like rituximab that we've seen, that even if you stop rituximab, I mean rituximab, the patients with lymphoma or chronic lymphocytic leukemia, for 6 months or even a year, they do not respond at all to the vaccines. Mm-hmm. Mm-hmm. The problem is that you don't know, especially for anti-CD38, who is going to respond and who is not. And this is something extremely important, because with the anti-CD38 monoclonal antibodies, we have seen that almost 50% of the patients respond to the vaccine, but we don't know who will respond and who will not. Possibly those on response to treatment, like complete response, for example, very good partial response, and those who have not severe lymphopenia. I talk about measurements that you can find from the full blood count, like lymphopenia, or the response that you know from your doctor, how much you have responded. These two data are important. So if you have a very good response and you have no lymphopenia, you have high probability of response to the vaccine.
Okay, great, thank you. And so in terms of active treatments, is there a specific one that would make someone, let's say, more susceptible to infection by COVID-19? Let's say someone on lenalidomide maintenance, is their immune system maybe running a little bit less, or somebody who's on a different drug? Like any insights on that?
I think that from what we had in our department, those under belantamab mafodotin, but don't forget that the license for this drug is for patients who have been given all previous therapies, so they are triple-class refractory, so they are very susceptible to infections. Only these patients I've seen that they had a higher probability of death with the new variants. Those who are on lenalidomide maintenance and those who are receiving VRD, for example, for therapy, and they were infected by COVID, with the new variants, they did well. I mean, they didn't want to go to the ICU or having, let's say, long hospitalization for severe pneumonia. So I believe that those patients who are having very active disease, not responding to therapy, who are receiving belantamab mafodotin after 4, 5, 6 previous line of therapy, they are more susceptible and they have to be very, very careful. They have to wear masks even if they have their vaccine, they have their Evucelt, so they have to protect themselves.
Okay, that makes sense. Thank you so much. So in terms of like a tandem transplant, let's say, does it still apply to like what we talked about transplants getting before and after, or is
you are going to get before and after, because in the majority of the cases, let's say you have a transplant, even 1 month before or even before that, you are going to have the first vaccine, even the one that targets Omicron 4 and 5. Then you have the transplant. You are having the first result 3 months after the transplant, and then you are going to have a second one. So after 3 months of the second transplant, when you are being evaluated for the response of the second transplant, then if you are having a very good response and your full blood count has recovered, then you can have the second dose.
And it's important for the blood counts to recover, because or else you won't have a response to the vaccine. Is that correct?
Yes, especially the lymphocytes.
Lymphocytes. Okay. I'm just trying to see here if I have one more question. Okay, I mean, this is a pretty simple one. In terms of the boosters, Pfizer versus Moderna, any difference between them? Any preference or?
No, the only thing that I would say is that if you have a vaccine that targets Omicron 4 or 5, that is dominant now in Canada, as I have seen a little bit before our connection, Omicron 4 and 5 also is dominant in Canada now, but Q1 has appeared to Canada, as I have seen. Then Omicron 4 and 5 is okay from any company.
Okay, so basically what it's targeting is what's the most important thing.
Yeah.
And you know, it is flu season as well, and a lot of the times someone will go and get their COVID vaccine and they'll be offered the flu shot. Any issues with getting two vaccines at the same time, or spacing them out?
Okay, I would recommend to have 1 week apart, but okay, if it is more convenient to have the 2 vaccines together, just have in mind that you may have a little bit more side effects, more probability of the having some fever because of the 2 vaccines together. So I would recommend to have 1 week apart, but you definitely have to have the flu shot also.
Yeah. Okay. So I think in terms of questions, that's it. I don't see any new ones that came in. I'm just double checking. Yeah, no, it's all good. So with that, Dr. Terpos, I want to thank you again for taking the time. I know it's 8 p.m. In Athens right now, and it's getting late. So after a long day's work, so thanks a lot. We really appreciate it, and we hope that in the future we'll have you again for. Hopefully, we won't have any more COVID updates, but you know, probably we'll see.
Okay. You may discuss other myeloma issues if you want.
Exactly.
Thank you so much.
Thank
I
you
hope
so much.
that I will visit Canada again soon. Okay.
We would love that. We would love that. So have a great evening. Thank you so much.
Thank you so much. Bye.
Cheers. Bye.